there are four key principles that differentiate Crohn disease from ulcerative colitis. And if you understand them well, there will be never ever any need to memorize any table to differentiate between ulcerative colitis or Crohn disease, or to struggle to understand the difference between Crohn disease and ulcerative colitis. And that is exactly the intention of this InstaLecture, to help you think that what are the differences between ulcerative colitis and Crohn disease. So firstly, that they are both an inflammatory bowel disease, because they are a disease which the key process is chronic inflammation. In chronic inflammation involving the GIT. Now, firstly, the most important difference is their location. That is the first thing you need to know. From the name of the ulcerative colitis, you get the hint that it involves large intestine mostly, because the name is ulcerative colitis. So that is true, because ulcerative colitis mostly starts from the rectum and then moves proximally, involving colon. And they usually do not involve the small intestine. On the other side, Crohn disease, though we classically say that they can involve any organ from the mouth to the anus, but it has been seen that they have a tendency to spare rectum. So Crohn disease has a tendency to spare rectum, and virtually all cases of ulcerative colitis always involves rectum. This is the first big concept that you need to understand. That means if an inflammatory bowel disease is not involving rectum, but involving small intestine, you need to think it as Crohn disease. On the other side, if an inflammatory bowel disease is involving rectum, but not involving small intestine, you need to think as ulcerative colitis, because ulcerative colitis mostly always involves rectum and then involves proximally the other colon. On the other side, Crohn disease can involve any organ from the mouth to the anus. They can still involve rectum. I'm not saying they cannot involve rectum, but they have a tendency to spare rectum. On the other side, ulcerative colitis do not involve rectum. This is a big key difference. So location-wise, try to look at two things. That is this inflammatory bowel disease involving small intestine, or is this inflammatory bowel disease involving rectum? If you get answer of these two questions, it will help you to alleviate your problem. This is the first big concept that I'm telling. And if you understand this, a lot of differences which are derivative of this concept of idea, it becomes very easy. Like which one would be associated with malabsorption syndrome? Well, that one which is associated with involving small intestine. Which one is involving small intestine? Crohn disease. Because the malabsorption disorders are basically disorders of the small intestine, because the absorption basically occurs in the small intestine. So ulcerative colitis typically do not present with malabsorption syndrome, but Crohn disease involves presence with malabsorption syndrome. They can present, which one would be presenting with vitamin deficiency, vitamin A, D, K deficiency. And so again, Crohn disease. Because Crohn disease is typically most commonly associated with vitamin D malabsorption out of all these vitamins. Which one would be associated, could be present with megaloblastic anemia? Answer, where the vitamin B12 gets absorbed. Answer is ileum. Which one typically involves ileum? Answer is Crohn disease. So again, the answer would be Crohn disease. Which one would be presenting with intestinal obstruction? Answer would be again Crohn disease, because typically the intestinal obstruction occurs in the small intestine, and Crohn disease will associate with thickening of the wall and the fibrosis of the wall, causing narrowing, the stricture formation. So further narrowing of the small intestinal lumen occur, potentiating to intestinal obstruction. So the first big concept which I told you, that is the location. Crohn disease typically involves small intestine. Ulcerative colitis do not involve small intestine. I'm talking about the difference right now. And ulcerative colitis, virtually all cases involve rectum, and Crohn disease can involve rectum, but have a tendency to spare rectum. This is the first big concept. And from this concept, you also get a lot of derivative concepts. Firstly, I told you malabsorption, because small intestine involvement is seen in Crohn disease. So malabsorption will be seen in Crohn disease. Megaloblastic anemia could be seen in Crohn disease, because that is involving ileum. Ileum is the site where the vitamin B12 absorption occurs. From this concept, also why there is a oxalate renal stone occur. That is also explained. Oxalate renal stone is typically seen in Crohn disease. That is also explained by the small intestine and ileal involvement. I have talked about this earlier. From this, you also get that Crohn disease has a tendency to present with intestinal obstruction, because intestinal obstruction typically occurs in the small intestine. So a lot of derivative concepts you can derive if you understand this first big concept. Next big concept, the difference between Crohn disease and ulcerative colitis is this, that both are chronic inflammatory disease, but Crohn disease is involving the whole thickness of the wall, from mucosa to the serosa, because you know that the wall of the GIT, they are of 4 layers, from inside to outside. That means from lumen to outside. Firstly, there is mucosa layer. Then after the mucosa, there is a submucosal layer. The third layer is muscularis propria, proper muscle layer. And the fourth layer is the serosal layer. So if I go to the whiteboard, I think it would be easy to explain this concept. So let me go there, because this is the second big concept which I am discussing right now. So there are 4 layers in the wall of GIT, gastrointestinal tract basically. So first layer is mucosa, M, I have drawn. Then there is submucosa, SM. Then there is muscularis propria. And last layer is serosa. Now, in ulcerative colitis, the inflammation is mostly localized in the mucosal layer. And sometimes it can come to the submucosal layer, but mostly in the mucosal layer that is limited in cases of ulcerative colitis. But in cases of Crohn disease, now I'm again drawing those 4 layers. Crohn disease is basically a transmural inflammation. That means it involves all 4 layers. They involve all 4 layers. That's why it is called, this is CD I'm talking. That's why there is a term used here that is called transmural inflammation. Transmural inflammation. Let me write it here. Transmural inflammation, which means that the inflammation is extended from mucosa, this is the mucosa, to serosa, the whole thickness, all the 4 layers. And basically transmural, if you break this term transmural, what does it mean? Trans means through. Like you can say there is a transatlantic flight. That means one side of the Atlantic airlines from the Europe to US, from the other side of the Atlantic. That is the trans means. And mural means wall. Mural means wall, like mural thrombus means wall, mural painting. So mural means wall. And trans means through. So transmural inflammation means that the inflammation is extending throughout the wall, from one end of the wall of the GI tract, because basically GI tract, this is the wall, you know, because this is a lumen and this is the wall. So from the lumen side, there is a mucosa, then there is submucosa, then there is muscularis propria. So all this thickness, the whole thickness is involved in the CD, Crohn's disease. That's why it is called transmural inflammation. This is the second big concept that you need to understand. And if you understand this, there are a lot of other concepts you can actually derive from there. So if this is throughout the wall, the inflammation is occurring, in which case do you think there would be formation of sinus tract or fistula? In case of Crohn disease or ulcerative colitis? Obviously in the Crohn disease, because this throughout this inflammation of the wall is occurring, and that could lead to perforation. Like if I use a eraser here, that means in this area what would happen, that there could be a perforation here, and perforation could lead to, that means let me draw it actually, I think. So if there is perforation here in this area can totally be empty, perforated, because this whole area is inflammation. So now this bowel could be connected with some other areas of the bowel, causing enteroenteric fistula, or it could be connected with some other organs like bladder. So this way, even with the skin, enterocutaneous fistula is possible. So I think you know that what is fistula is. Fistula means there is an abnormal communication between 2 epithelialized organs. So that is only possible when your whole wall is drilled out. So you can think in this way when I think about Crohn disease and ulcerative colitis. Like in my back, there is a wall is there. And ulcerative colitis means just someone is scratching on that wall because involving the superficial layer of the mucosa, just scratching here. That is ulcerative colitis. But Crohn disease means someone drilling the wall from one end of the wall to other, drilling through the wall actually of this and creating a abnormal communication between this room and the next room. That is the idea of the fistula. You can think in that. So obviously, transmural inflammation is seen in Crohn disease, and as a result, what happens? As a result, there is formation of sinus tract. There is a formation of the fistula. This is also a derivative of that concept. Even the whole wall thickness involvement, there could be extensive fibrosis, and there could be stricture formation due to that fibrosis. So Crohn disease is also associated with narrowing of the lumen, stricture, and fibrosis formation, which is not seen in the ulcerative colitis. So the second big concept which I told you is that Crohn disease and ulcerative colitis both are inflammatory disease, but the inflammation is not involving the whole layer of the GIT, the whole wall of the GIT. In case of ulcerative colitis, they are only involving superficial mucosal layer. Typically, it's a mucosal ulceration, ulcerative colitis of the colon and the rectum. On the other side, Crohn disease is involving the all four layers. It's a transmural inflammation. Trans means through and through, mural means wall, involving all the four layers from the mucosa to serosa. And from that, you understand some other differences like stricture formation, extensive fibrosis formation, fistula formation, sinus tract formation. This would be typically a characteristic feature of Crohn disease and usually not seen in ulcerative colitis. This is all the derivative of this concept. The third big concept is this, that usually ulcerative colitis involves in a continuous fashion. That means the whole pathology is involving through and through in a continuous fashion, not involving any skip area. Let me draw it this place, then I think it would be again easy to understand. So the idea is this, that suppose this is Crohn disease. Crohn disease may involve, this is the GI wall of the GIT. Crohn disease may involve some part of the wall of the GIT, some part of the maybe small intestine, and then skip some part. This area is normal. Then again, they're involving some part again. This area is normal. So that's why the pathology is basically jumping, skipping from one area to another. That's why they're called skip lesions. So some normal areas are in between, and there are some abnormal pathologic areas are there. On the other side, ulcerative colitis, this is in case of CD. In case of ulcerative colitis, the whole pathology is involving continuous fashion. There is no skip areas in between. This is the third characteristic feature or differentiating feature between ulcerative colitis and Crohn disease. Skip lesions are usually seen in Crohn disease, and there's a continuous pathologic lesions usually seen on the ulcerative colitis. The next big concept between ulcerative colitis and Crohn disease, in the biopsy, you need to look for the presence of granuloma. In Crohn disease, usually 30 to 40% cases, roughly 35% cases. Some studies even seen up to 60% cases. So the studies they have seen from 35 to 60% cases, there can be presence of granuloma, particularly non-caseating granuloma in cases of Crohn disease. But in ulcerative colitis, non-caseating granuloma or granuloma is not seen. So let me again explain this concept a little bit there, that what is this idea of non-caseating granuloma. Let me again clear everything. So I think you know that granuloma is nothing but a microscopic aggregate of inflammatory cells, particularly activated macrophages. And granuloma comes in two variants. One is called caseating granuloma, another is called non-caseating granuloma. Caseating granuloma means at the central part of the granuloma, there will be some areas of caseous necrosis. CN, what I mean to say, caseous necrosis. Then there will be some epithelial looking cell like Sandel or your sleeper, which are basically activated macrophages, but they look like epithelial, they smell like epithelial, they feel like epithelial. That's why they call epithelioid, ending with YD, but actually they are not epithelial cells, they are activated macrophages. So these cells are called epithelioid cells. These are usually seen in the granuloma. And also you see a lot of lymphocytes in at the periphery of this macrophages. So this whole microscopic structure, they are called granuloma. And where you see this granuloma, and also you can see giant cells, which are this fused activated macrophages, Langerhans giant cell or foreign body giant cell. Giant cell means you'll be having a lot of multiple nuclei arranged them. This is also a key component we typically see in the granuloma. So not all the granuloma, they have centrally this caseous necrosis. The caseous necrosis may be absent in some granuloma. Those are called non-caseating granuloma, NCG. And a classic example of this non-caseating granuloma is this Crohn's disease. That means they don't have a central area of caseous necrosis in the granuloma, this microscopic structure. Another one you can see typically sarcoidosis, which is also an example, typically seen in lungs or skin biopsy or other places. Because sarcoidosis is a multisystemic disease. And Crohn disease typically you see in the GI biopsy. And this is an example of non-caseating granuloma. Is an example of non-caseating granuloma, NCG, non-caseating granuloma. So I told you that granulomatous inflammation, I already discussed in the lecture on the inflammation. Granulomatous inflammation is a subset of chronic inflammation, which is characterized by granuloma formation. And there, as there is granuloma formation, this inflammation is called granulomatous inflammation. What is granuloma? I think granuloma as this way that the body is trying to imprison certain substances or certain offending organism which can create havoc. It's like putting some criminals in the jail, some jails, so that they cannot come out to the outside of the jail. And those jails, those small jails in the body are granuloma, where we're actually creating a border, a circular structure where they cannot come to the outside and cause some damage, just like we do not allow criminals to come outside of the jail and cause damage to the civilians. So they are creating some kind of fence structure in the body, which are usually contain a lot of activated macrophages, and at the periphery they contain a lot of lymphocytes and macrophages. These structures are called granuloma. And granuloma morphologically could have centrally caseous necrosis, and they may not have caseous necrosis. Those granuloma which do not have caseous necrosis, they're called non-caseating granuloma. And our topic of the day, Crohn disease, is an example of non-caseating granuloma. And this non-caseating granuloma is not seen in the ulcerative colitis. It's seen in Crohn disease. So this is the next big concept which I was going to explain. Having said that, please keep in mind that not all cases of Crohn disease present with caseating granuloma. As I told you, studies have shown that from 35% to 65% case of caseating Crohn disease can have non-caseating granuloma, but still 40% to 65% cases may not have granuloma. So this is, you need to keep in mind that if it is present, it is definitely a very useful distinguishing feature between this thing. Because if it is there, definitely it is Crohn disease, not ulcerative colitis. Ulcerative colitis is not associated with the presence of this thing. Another feature is that if you get crypt abscess also is quite a useful feature. Crypt abscess, if it is present extensively, it is a more characteristic feature of ulcerative colitis. And what is crypt abscess? Crypt abscess means that within the crypt lumen of the GIT, there is presence of neutrophils. Please keep in mind, not any other inflammatory cell, but the presence of neutrophils. If that is present, this is a useful morphological feature which favors, I would say, ulcerative colitis. Now, what are the other distinguishing feature which I like to tell? If there is extensive gross bleeding, rectal bleeding that is present, this also favors ulcerative colitis, because bleeding is much more common. Bleeding diarrhea, blood with diarrhea is much more common in ulcerative colitis than Crohn disease. Crohn disease can have bloody diarrhea, but it's much more common in ulcerative colitis. Another concept which is quite related to that, this cancer development. Cancer development is if Crohn disease is presenting with colon involvement, then only there is a chance of cancer development, because colonic cancer, because that is all the time Crohn disease may not present with Crohn colon involvement that you need to keep in mind. But ulcerative colitis is always involving causing colitis, and there is a obviously significant chance in the cases of colon cancer development. But if Crohn disease is involving colon, then the chance is there. That is another key concept. And the lastly, I would like to tell about the always examine the patient or always get the history that is there a patient of perianal involvement. If the perianal involvement is there, perianal pathologies are there, anal fissure, anal abscess, this is also a characteristic feature of Crohn disease, usually not seen in ulcerative colitis. So if I summarize the key points, a lot of derivative points are there. That location wise, first look at that, is involvement of small intestine is there, yes or no. If it is there, it is more characteristic of Crohn disease. Because ulcerative colitis, as the name colitis, that means they are already telling you from the name that I am not involving small intestine, I am involving colon. And typically the Crohn disease, they usually involves the distal small intestine and colon. This is the part there. Rectal involvement is always characteristic of ulcerative colitis, because 95% to 100% cases of ulcerative colitis usually involve rectum and then move proximally. So if the rectal involvement is not there, that goes against the diagnosis of ulcerative colitis. The next concept I told you, both are chronic inflammation, but they are involving the wall of the GIT. But ulcerative colitis is only involving superficially, the mucosa and sometimes up to submucosa. But Crohn disease is a transmural inflammation. Trans means through and through, mural means wall. That means all the 4 layers of the wall from mucosa to surface. And if you understand this, you understand why there is stricture formation, why there is sinus tract formation, why there is fistula formation, which is a characteristic of Crohn disease. Why, and also you can understand why there is intestinal obstruction typically seen in Crohn disease, because the narrowing of the lumen, particularly the small intestine. And small intestine involvement also tells you that why there is vitamin A decay malabsorption, why there is vitamin B12 malabsorption linked to megaloblastic anemia, why there is malabsorption syndrome. These features are characteristically associated with renal stone. They are characteristically associated with Crohn disease. That's basically on the point number 1 I told you, that is the derivative of that. Next big concept about the difference between Crohn disease and ulcerative colitis is that Crohn disease usually causes skip lesion. That means some pathology here, next area normal, again some pathology, next area. So the pathology is jumping, skipping from area to area. That's why it's called skip lesion. Ulcerative colitis is usually moving continuously. There's no skip lesion there typically in them. The next concept I discussed already, which I'm revising right now, that granuloma formation. Crohn disease is a typical example of granulomatous inflammation. And what kind of granulomatous inflammation? Non-caseatic granulomatous inflammation. I told you from 35% in some study to 60% cases, we have seen that Crohn disease can present with granuloma. What kind of granuloma? Non-caseating granuloma. And that is not a feature of ulcerative colitis. So if you see this feature in a biopsy, definitely it goes in favor, diagnosis goes in favor of Crohn disease. Then I also told you that between ulcerative colitis and Crohn disease, another feature would be that is the manifestation. If there is a gross bleeding, rectal bleeding is there, that is more in favor of ulcerative colitis rather than Crohn disease. Crohn disease bleeding can occur, bloody diarrhea could occur, bloody diarrhea, severe rectal bleeding, this goes more in favor of ulcerative colitis. And the perianal involvement, which I told you, if the perianal involvement is there, that is also a characteristic of Crohn disease. Anal fistula, fistula in ano. If these features are getting the patient, that is more in favor of Crohn disease rather than ulcerative colitis. So these are the key differences between ulcerative colitis and Crohn disease, which can help you to differentiate them quite easily. And I think if you understand few basic concepts, that one is Crohn disease is a transmural inflammation, while that is a superficial mucosal inflammation. And as the name ulcerative colitis, it basically involving rectum and colon. And this one also involving, Crohn disease can involve anything, but typically involves small intestine and colon, and usually have a tendency to spare rectum. If you understand this basic concept, you can figure it out, the differences between ulcerative colitis and Crohn disease on your own. And I will continue to discuss about ulcerative colitis and Crohn disease and other characteristic features in the coming InstaLecture also. So thank you very much for attending this lecture.